guys, good morning. Good morning, guys. This is Dr. Jenny, physical therapist and doctor of physical therapy, clinical geriatric clinical specialist, and also creator of Balance and Fall Support Group in Aging Adults. If you are in United States of America, good evening. If you're in Philippines, it's morning right now. So magandang umaga, guys. And also, if you're in United Arab Emirates and Saudi Arabia, Salam alaikum, everyone. So, Teepa, I work in Saudi Arabia for 5 years and also United Arab Emirates. So, welcome, guys. Tonight, it's a very special night. We have again in our podcast in Fissiogen PT and Wellness, and we have in our Balance and Fall Support Group, Thanks God It's Thursday. So, every Thanks God It's Thursday, we host entrepreneur, therapist, academician, innovators. Innovators is equal to scientists, right? So they are so awesome. So tonight we have 40 years of experience. She's a dementia expert. When you hear about dementia, you automatically think about her. You know, I was new in United States of America in my previous company, and I saw her doing the course about dementia, and she's really awesome. As if she is the one with dementia. Exactly, she's acting like one. So without further ado, guys, she is an occupational therapist, a Master of Science, and a Fellow of the Academy American Association of Occupational Therapists. All right. So she has 40 plus years of experience as clinical and also in an academic degree. She did many research. I saw her CV. I think 3 pages is not enough. Lots of research, lots of books, lots of speaking engagement. So we have her tonight. So drop what you're doing. It's only a few minutes tonight. So welcome, Teepa Snow.
Welcome. Yeah, well, it is great to be here, Jen. I'm just gotta be, yay. You guys do great work. I love the connections you're making and the way you make people feel welcome. So thank you. Thank you.
You are welcome, Teepa. And thank you so much, by the way. We also, guys, finished the Geriatric Rehab Summit. And we have Teepa Snow as one of our speaker, and she did the closing remarks for everybody on the second day. And her approach in her speaking is unique. So knowing that we usually do when we do a research like webinar, do the slides, but in our course in the Geriatric Rehab Summit, she showed a case and she explained how does it work. So Teepa, before we go into deeply about those things about dementia, so tell us more about yourself and what I missed.
So yeah, well, let's see. I'm originally from West Virginia, but I moved to Pittsburgh area for a little bit. And then I've been in North Carolina for years and years and years. What I have done is had the good fortune to work with a number of other healthcare providers and professionals. Now, I taught at UNC School of Medicine and the School of Occupational Therapy. I've also done lots of guest lectures like at Efland PT, master's and doctoral program there. And I've taught at Duke School of Nursing. So I've done a lot of teaching, but I also have done a lot of clinical work, head injury, stroke, rehab, both at UNC Hospital, but Duke Hospital as well, and then worked in head injury. And that's before I got really involved in Alzheimer's and dementia. So after I got really hooked into that area and worked with the Alzheimer's Association for several years and did their education, that's when I really determined, you know, where I'm meant to be. I'm meant to be in dementia. Because there's a lot of misunderstanding about dementia, and people living with dementia are definitely going to need support. I mean, there's no way around it. It's part of having the condition.
Exactly. And they are very complicated. We have many stages. And we also, guys, I didn't also said about you from the beginning that Teepa Snow is the CEO and founder of the Positive Approach to Care. So previously she is doing academy, teaching. She's a professor in Duke University, I believe, and also doing those like clinical. But right now, she wanted to help and go deeper also in teach us as a clinicians to learn more the techniques on how to engage with clients with dementia. Tipa, you know what? I'm only 9 years here in America, and I was surprised how many we have dementia clients. And it's really challenging because I work in an assisted living facility and they have a dementia memory care. So as an expert, what will be your tips for us as a clinicians doing home health, assisted living, and SNF?
Yeah. So one of the really tricky parts about dementia is everyone's a high falls risk when somebody gets diagnosed with dementia. I mean, and so that's one of the things that makes it difficult. Having a diagnosis of dementia increases your risk of falls and fall related injuries. And so right away, there's not anybody you should ignore. There's not anybody you can take off your risk list. There's not anyone really living with dementia who's going to be safe from gravity. So once we take that into account and we know that the brain is going to change and change and change, but human beings often in their very core come into two groups. Okay, that might help. So there are safety seekers and there are risk takers. Okay, so some people are, if things get a little bit dicey or a little bit scary, they go into a, whoa, it's scary out there. And so they tend to go more immobile.
Mhm.
And then we have the second group that's like, oh, an adventure. And they're going to be your fallers.
Uh-huh.
But what that means is we can't ignore the immobile people because as a human being, there's no way to be totally immobile. It's not safe, it's not wise, and it's not even functional. So people need to move and then they need to stop moving at times. The problem is with dementia, people tend toward one or the other, or they do one for a while and then they switch and they do no mobility. So what it means for us is we want to look, who are we working with? Are we working with a really safe seeker, which means tending to immobility and tending to reduce movement? And we want to get them up and moving because the reality is if they start immobilizing themselves, they stop being able to do things, they're going to prematurely lose all their skills, not just gross motor skills and balance skills. We're talking about fine motor coordination skills, engagement and life skills, community activity skills, socialization skills. So it's really critical to start looking at our folks and say, okay, a safety seeker. So I've got to make them feel safe while I'm working with them. So those folks tend to want a little more contact. They want a little more, whoa, slow. You have to really get them comfortable with you, and then they'll take risks. So it's really about building relationships. Now, your risk takers, they're the ones where your eyes go, it's like, oh, wow. And they tend to be a little quicker, a little more impulsive, a little less planner. And so what can happen is they're in the middle of doing something and you're like, oh my heavens. But realizing I've got an impulsive sort of risk-taking person, I need to give them enough challenges and I need to be close enough to monitor, but I've got to be more prepared for Jenny, hey, Jenny. And I've got to be able to get my hand there and get in support quickly because you're going to do things that I don't anticipate because my brain is not your brain. So once I start figuring that out, then I have to help families and staff because let's just lay it out there. I'm going to go ahead and give it to you. For somebody living with dementia and they're a risk taker, shall we give them a walker?
And that's what we keep doing.
I mean, why?
Them, right?
This person, if they're a risk taker, they are not going to use that walker.
They don't understand, right? They don't understand.
Get it. They sit it off to the side. It's, we've got to teach them to use the environment, or we've got to be more proactive in that because we've got to teach families. She's not going to use the walker. I mean, as much as I'd love to give it to her, it's not going to do us a lot of good. It's a risky we're making it more risky. If she uses it sometimes, doesn't use it at other times.
Yeah.
But it's our brain really, but we always give walkers. And it's like,
Mm-hmm.
now, if you have a safety seeker,
Mm-hmm. Okay.
yeah, they're going to love that. But what they're going to do is hug the walker.
Mm-hmm. Yeah.
So then, what are you going to do? But that's an example of how I really do believe we have a huge role to play in helping people live with dementia and help people who are living with people living with dementia do a better job of supporting.
Wow, that's really true because I don't know what kind of stages they are. Sometimes you really overlap.
Mhm.
They're so sound of mind in the morning. We have the sundowning in the afternoon, and then you will be surprised. Delirium is kicking in later on. Then you will check with UTI. So this is really complicated, guys. So we have heard also and learned, Teepa, that we need to also be sure that this client has diagnosed with dementia
Absolutely.
versus having dementia characteristic, but they are treatable because
They
it's like
are.
vitamin
Yeah.
B12 deficiency, hydrocephalus, something like that. So what can you
Depression,
say about that?
anxiety. Yeah. I mean, there are a lot of things that look like dementia, but are treatable. And they're treatable in ways that we can actually change people's lives because they don't have a chronic, debilitating, deteriorating brain disease. What they have is something going on that if we don't catch it and we don't do something can cause irreparable damage. But in fact, if we catch it and notice it early on, we can make a huge difference because we turn around a condition because it never was dementia.
Mhm.
So things like thyroid disease, things like, as you said, vitamin B12 deficiencies. We could have, there's numbers of conditions. And as I mentioned, depression and anxiety and sleep problems.
Mhm.
Now, somebody could have problems with insomnia and they will look very much like they have dementia, but we also have medications that people take. Anything with a Benadryl in it, a Tylenol PM can start being something that over time, the person looks more and more out of it. They're having more and more trouble. And we think, oh, it's just dementia developing. No, they're on a medication that's an over-the-counter med that they're using, and it's really stopping the acetylcholine from working in their brain.
Yeah.
So we've got to get curious about people, and we don't want to make assumptions. We want to do assessments.
Exactly. Mm-hmm. Yeah, and we always want to check and reconnect with a primary care provider. Do you have already a diagnosis of dementia or is it early dementia? When did you diagnose? Because some family member, they even come back to us, Jenny, is it my mom or is it the doctor who diagnosed it?
Right. Yeah, where did the diagnosis come from? Because if somebody has dementia, that's not actually a diagnosis, it's a syndrome. We know that they have some symptoms, but we got to be careful because only about now, okay, so this is a quiz, Jenny. Let's see. You ready for your quiz? Out of 100 times, if there were 100 cases, how many times will physicians do a good workup to find out what's happening for somebody? Out of 100 times, how many times will they do a really good dementia workup?
Workup? I'm not sure. Maybe out of 100 times, let's say 25.
You're pretty close. Only 20% of the time will they do a good workup. Only 20% will they do anything more than a few questions, ask the family if it's been going on for a while, and then mark it as dementia. It's really not okay. And it wouldn't be allowed to happen with any other health condition. But even when you're older, people should do an assessment, and that's not happening. And so we may be misidentifying and mishandling things because we're not getting good data from a medical provider. And so saying, tell me more about the kind of dementia they have. Oh, I don't know. Well, then it's time to go, well, I'm not I'm just curious because I'm not seeing a consistent symptom pattern for one of the ones that I'm more familiar with. And, this is where learning about dementia really comes in handy. I mean, we know we have categories of dementia. We have frontal temporal dementias and Lewy body dementia,
Mhm.
plus Parkinsonian feature, and we've got
Yes,
vascular dementia and Alzheimer's, but then we have a whole host of other dementias.
yes,
And when we have a provider that isn't curious enough to try to determine what form or forms of dementia do we think we're looking at, I find it not very helpful for the families, for the care staff, or for me, if I don't have somebody curious enough about what are the core symptoms, how did they develop, so that I can sort of figure out, okay, so, frontal temporal. So we should be able to keep some physical activity going pretty nicely, as long as we're not counting on language if the person has temporal lobe issues. But I will not expect much for sequencing in care activities, but they should be able to really possibly still swing a tennis racket. So I want to make sure they have somebody partnering with them so they get a chance to swing that tennis racket and hit that ball, because that's going to be something they can do spontaneously. Whereas if they're trying to figure out how to get their clothing on, they get stuck.
wow, good point. Yeah. So just by getting the history taking, we're able to come up with the best plan of care and style as a clinician. So that's really good point. Like me, I have Parkinson's. I'm a Parkinson's specialist. So if I have a Lewy body dementia, I met them. That's why I applied my training for that LSBTB to them. And then the wife was surprised that he was able to follow, and
Yeah.
I explained to them, so you're forgetful and your dementia is like this.
Yeah.
And he even confused, am I a Parkinson's client or I have dementia? I just explained to the wife. So education is really important in everybody.
It
So
really is.
mhm,
Yeah. I mean, I think there's a discounting, a huge discounting that early in dementia, only about 50% of people with dementia don't have an interest in really figuring out what is exactly going on with me. Why am I having trouble here and there? They really do want to know what they can do to keep themselves well and fit and engaged. Half the folks that, however, are not going to have that skill early on because they have damage in their prefrontal cortex where you have self-awareness, and they think they're fine already. They don't need anything. They're fine. And that's hard because those are two different groups of people. So we're going to have to recognize that.
mhm. Yeah, and also I agree, especially whenever I treat my clients, I always ask the family member who's the primary caregiver in the house, you know? So I really ask and history taking first, what's the likes and dislikes of Mr. Smith, you know? And so that because I want to win him, knowing that I will be the therapist, I want him to be like buddy buddy, or else first day clash, you know.
Boom, boom. Yeah.
Yeah. Why do you think it's important, Tipa, that there will be a good carryover if there's a good familiarity, same person, and what will be your techniques for a caregiver standpoint in taking care of them?
Yeah. So how do we get both this carryover? One is leaving a session with a positive last message. I loved how you worked with me. You worked fantastic. That work we were doing, where we were really doing our arms like that when you were walking. Wow, I really like seeing that. Show me that one more time. And so what I'm doing is I'm reinforcing my face, my voice, those motions right as we end our session. And then I say to the family member, so I want you to do this first and then say, now I think that woman, that Teepa, she said something about we should do this. And then she said we should do dun, 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 dun. And so I cue up family or staff, because if I don't get them engaged, I have to engage them as well as the client early on. to get the best bang for the buck. So if I find something that really is working and it's something they can follow through on, and I say 5 minutes, do it for 5 minutes, and then great work, we'll let her know. Check. Because if not, what ends up happening all too often is you have to keep working on it. Come on, let's do it a little bit more. What happens is people wear on each other. And so it's starting off with 5 minutes, little segments, because all too often with carers, they're tired and they get, I'm just going to say it, they get a little cranky. I mean, people don't mean to be cranky, but they sound whiny or cranky. Come on, you know, you've got to do your exercises. Come on, let's try it. Come on, come with me. And instead of going, oh, Jenny, oh, hey, listen. Oh, I love that shirt. Let me see, stand up. Let me see it. Now, when I did that, didn't you want to stand up?
Yeah, of course.
Yeah, because I took away the, Jenny, I need you to stand up because you need to stand up because you've been sitting for a long time. And instead I figured out how to make you want to stand up. I love your shirt. Stand up, I want to see it. And it was a spontaneous, automatic. I used my voice and my presence to trick your brain into wanting to stand up.
Yeah, that's really good because you just say it directly. But for us, usually, if we don't have training, we will going to say, all right, Mr. Smith, I want you to stand up. And then you were going to explain. And they really not participated. The more you talk, and we always remember, we keep saying that we need to follow the 90 seconds rule, right? So we need to wait 90 seconds. All right, Mr. Smith, let's stand up, let's say. So I cannot say anything, another thing. We need to wait for 90 seconds, guys. And then it should be short. It should be concise. And it's very important, the tone.
It's huge.
Teepa, is it like
Jenny
upbeat or soft? What do you recommend? Like calm?
Jenny. Stand up.
I will stand up.
Yeah. So what did I do right before I asked you?
Like, you call me, you talk to me,
I said,
and then you get my attention, and then later on, eye contact. Oh, okay. So you
I went,
catch my attention.
Jenny. And I'm waiting.
Look at you.
And she's looking. She's got it. She's got it. Go. And then I did this. Stand up.
Okay. And I did demonstration.
I did the demo just right before I gave the words. So her brain saw me doing something. And then I said what I did. And then I gave the up motion with my hands. And your brain went, oh, she wants me to stand up. And there was just pattern that I'm using. And so it's visual cue, verbal cue, and then see if you get the movement cue. Happen.
And it applies in different stages. We really need to be animated. Like we're moving. Mr. Smith.
Yeah.
Let's stand up. And then they're hard of hearing. Yes, and then stand up.
And then we do the yelling. And so instead of doing the yelling, you go, stand up.
Okay.
So the movement then, because what we don't know, is it because they didn't comprehend or they didn't hear? So if we gave them the verbal and we didn't get what we were looking for, and yet they're connecting, they go, we aren't sure comprehension or hearing. And so I want to give them a new kind of cue to help. So I'll go, stand up, to see if my motion, my visual helps them get the message.
That's really powerful. That you're always like that, Teepa. I really thought you want me to stand up. You're always in the character. You know what I mean? And that's really a good educator. So I'm really standing here and then you're explaining, okay, you like it. And then, okay, it's really, you're in the character of teaching on stand up. Let's do this, you know?
Hey, Jenny.
What's that?
A drink?
Okay.
You have one?
No.
No. Oh, let's go get one.
That's good. So what will be? That's activity. And now I did that too. I have a friend. Mr. Smith has difficulty walking and he doesn't want to do exercise. So what she did, she's my friend, and she said that, oh, I didn't know. We need to get what their hobbies, they want.
Motivators.
So
Yeah. What are the
he is an
motivators?
artist before. So he saw all the paintings in the house, and she said, Mr. Smith, I just saw nice painting in the living room. Let's go and check. Tell me more about it. And then he walked. But she will not say, let's walk and do your exercise. No. So
No.
that's really good.
And so, I started drinking and then said, oh, you don't have a drink. Come on, let's go get you one. And so it's that, and so again, I have to learn about you. What will help you engage with me? Because if you could do it on your own, you would. You're not doing it. So somehow I've got to help you initiate that. I've got to get the click.
That's really good. You have lots of techniques, Teepa, and that's why you call it positive approach, because you really need to have how about this is like second to the last question. I know we have a very short time for you, but I really appreciate this. We have clients, they keep saying let's go out, or even it might be unsafe for them to go out. I want to go home. I want to go home, but they are already home.
Yeah.
So what's the approach for that? Is it like a little bit of lie, or tell them the truth that we are home?
Okay, so let's look at what in the brain is broken. So in their brain, the primitive part of their brain, their hippocampal area, they have a part that's supposed to be a wayfinding system. It is supposed to help you find your way from point A to point B and back to point A, and recognize point A is your home base.
Okay.
This is where you are. And so there are cues around you that say, this is where I'm supposed to be. So when someone says, I want to go home, it means the place I'm in doesn't feel safe. It doesn't feel like my home base. So what I know about the hippocampus is if I take it through a doorway or two, if I make it go into another space and maybe even a third space, when it comes back to the first space, it's more likely to go, this is where I'm supposed to be now. But I have to take it to unfamiliar, quote unquote, other places. And so the hippocampal area tends to reset itself as we go through doorways. It's just one of its features. It has to go, oh, so I'm in a new room, reorganize, reorient, so I'll know how to get what I need in this space. So as we go, I will take people from one space. I say, you got to get out of here. You want to go home. Well, come with me and let's see if we can figure out how we get out of here. So we're going down the hall and I'll say, now, should we turn? Let's turn this way. Oh, no, this isn't how we get out of here. Okay, hang on. Let's make a turnaround here. Let's head back over here. And so we go on some journeys. So I will walk with people and I will often say, well, let's get out, and we go into the courtyard and we walk around the courtyard, and maybe we go into the other part of the building. And then and I always have a 911 caller on me, but I'll take people to different spaces, because often when I bring them back, that's when people will say, well, why didn't you bring me here in the first place? And it's like, I am so sorry. This is where you were wanting to be. Took me forever, didn't it? But it's actually the trip that allows people to feel like they're home. So one thing I'll do is take people places. Second thing I'll do, you be the one who wants to go home. Okay. You tell me you want to go home. Go ahead and tell me you want to go home, Jenny.
Yeah. I want to go home. I want to go home now, Teepa.
Oh, you want to get out of here. You're ready to go home.
Yes, yes.
Yeah.
I want to see my dog.
Oh, your dog. Oh, is it a little dog or a great big one?
No, it's a puppy, like small
Oh, it's
one.
a puppy. Oh,
I'm sure
I
he
love
missed me.
puppies. Oh, she needs you. Yeah, puppies need mommies, don't they? Now,
Mm-hmm.
does she have puppy teeth? Does she
Yeah,
bite?
yeah.
Ooh, ow, man, they hurt when they bite, don't they? Oh, but they're so cute.
Yes, yes. I
Yeah.
miss my puppy.
I bet you do. I miss my puppy too.
Her
Oh,
name
hey,
is
Jen.
Yappy. Yappy.
Yuppie. Oh, wow. Now, I had one called Freckles when I was a little girl. Oh, hey, Jenny, come with me a second. I want to see if we can go do something.
You're bringing me home?
No, I can't get you home, but I want to show you a picture of a couple puppies. I want you to take a look at them, see if it looks like your yuppie.
Oh, okay. As long it's puppy. I like my puppy.
Yeah, let's go look.
Okay.
Now, so what I did was called validation. I validated your feelings. You don't want to be here. You want out of here. I
Uh-huh.
got to find, I used a lot of reflection, which is giving you back some of the information you gave me, means I'm
Mm-hmm.
listening.
Mm-hmm.
And then what I did is I gave you some options like, so is it a big dog or a little dog? And your brain started to think about the conversation
Yes.
and you let go of home a little bit. Because what you're
Okay.
really telling me is I'm lonely. I don't feel like anybody cares. And the fact that you picked a puppy, you also have a job, you have value, the puppy's relying on you. You feel like you don't get that here. And so now what I'm going to do is I need your help. Because what I want to do is figure out what's missing in Jenny's life. Why does she need to go home?
Okay. That's pretty good. Yeah. Is it like almost the same as the approach that the patient has their dog? So they will feel that they have company and
Yeah.
authority that I am like
So
responsible.
sometimes, yeah, so sometimes the animals that you can stroke,
Mhm.
sometimes it's they want to go home because they're hungry. And so I start to find out, I'll say, now, are you gonna, when you get home, are you gonna cook something or are you gonna do something? I've got to fix dinner. Oh, you got to fix dinner. Now, are you fixing something hot or just you gonna do a sandwich? Something hot. So what I'm really trying to figure out is going home means I'm going to a place of comfort. So how can I help them feel comfortable? And I know I can't take them home, but maybe I can bring them home.
Oh, that's really good. So is that a majority of the approach? I really like the one-on-one giving scenario. So on the positive approach to care, Teepa, tell us more. How does it look like? Is it like you're showing us a video of a scenario and you will teach us the technique? And
Mhm.
how does it work? Tell us more about it.
So yeah, so what we do is we go over, we'll demonstrate the technique, and then we'll give you a scenario, and then we'll ask you to try out the technique, and then we'll coach you. So as you develop your skill, we'll say, what do you think? Now, did that feel pretty good? Or did you ask a yes, no question? Or did you ask an either or question? Oh, I did yes, no. So let's try it as an either or. So would you rather go home or would you rather just get out of here? Try that. Is it just getting out of here they want, or do they want to actually go somewhere? Let's sort of try that. See what happens when you say those words. And so we work on skill development. So right now you want to say those words, don't you?
Yeah. Mhm. So that's really good. So right now, you're teaching us the technique. We do role play. And
Mhm.
then is it like self-paced when we
It,
have those?
yeah. And so what
Mhm.
we do is we recommend then after we do a 2 hour segment, we say, go work on those skills. And we would love for you to come back and let us see how you're doing.
Wow.
Because until we can see what kind of progress you're making, and we ask you to try it with, somebody that you could be on Zoom with. Could you have a friend you could bring and show us how you're doing? So then we can build more skill and then more skill, because,
Yes, yes.
drinking from a fire hose will just overwhelm you. But
That's really good because just like in the geriatric rehab summit, I was surprised when you begin with a video and then only from one video we learned a lot already and you showed the techniques, this is the first style and this is the second style. What did you learn from this character, and what's a better approach to that? And that's really a different approach, you know. So Teepa, that's really good. What can you give us advice as a clinician? So in this kind of time, people are looking forward for us to be better with this loss of people needing our care.
So what I would say is get really curious, which you clearly are a very curious person. I think we need to be very curious about the people we're working with, but about our own skills and about our own potential for, like, I wonder if what I did was helpful, or if the reason they're not doing it is they didn't get the message I sent, or they didn't like the message I sent, or something else. Let me try changing the message a little bit. I think we need to be willing to start from a base, and then if it's not working, we give it another chance, but then maybe it's time to go, okay, this feels like I'm trying to push an agenda at somebody and they're pushing back.
Okay.
So instead, I'm going to pause and see, what is their agenda? What are they interested in doing? And I'm going to try something fairly automatic, which is, Jenny, hey, and see if I can get you to take my hand. Because if you will shake my hand, that's a starting place.
So that's a positive approach. And then, or else if they ignored us, so that's
if they don't take the hand, it's like, did they not see my hand? Did they not want my hand? And so then I'll turn sideways and go, not wanting to be touched today, huh?
Okay. So that's really good.
You thirsty? So now I've got to go through what are common needs that humans have? Intake, nourishment and hydration, energy, getting up and doing something, or sitting down and resting or sleeping. Output, do they need to put something out? Could it be saliva? Could it be pee, poop? What do they need to put out there? Oxygen. They need to breathe out. And then, are they comfortable? What makes people comfortable? And are they in pain? Because nobody wants to be in pain and nobody likes being uncomfortable.
Yes.
So, it's sort of figuring out what's driving their behavior, because something is driving it. How do I help?
Awesome. Yes. Is it only for clinicians, or we can refer our caregivers?
You can refer caregivers. We work with people living with dementia. We work with family members and friends. We work with children, and we work with clinicians, and we grade it or modify it based on the audience that we're working with.
That's really good. Speaking of children, and I believe you work with autism at one point, and that's a really unique about you. So tell us more about that story, Teepa, before we close, if you're okay. So Teepa itself is unique already.
It is unique. And I got that name. My given name was Teena, which my mother thought was an incredibly clever way of spelling Tina, Tina. Which, yeah.
Like Christina, we call them Tina. Okay.
Exactly. Yeah. And so Teena, it's like, she found it in a book. And it's like, it's not, because nobody knows how to spell Tina. But when I was a teenager, I worked with a little boy that had autism, and his name was Michael. And Michael couldn't say Tina. He had a speech problem and he had autism. And he'd go, hey, Teepa, tell me a toy. Teepa, 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 Teepa. And so instead of Tina, he said Teepa. And everybody started calling me Teepa, because that was Michael's name for me. And so everybody would say, hey, Teepa, Teepa. And so that was Michael. And so, but then gradually over time, more and more people called me Teepa. And so by the time I was in my mid-20s, nobody called me Tina. Everybody called me Teepa, including my family. So I legally changed it to Teepa.
Oh, that's really
a given name. It's a truly given name.
I haven't met a Teepa.
Nope.
No, I haven't met that. And the Tina itself, how you spell Tina with Teena, I haven't seen that too, because we're used to be rare. Tina. Yeah. So you're always unique, right? So thank you so much.
One way of saying it. Yeah.
I'm so grateful, Teepa. I'm just used to see you. I'm just starstruck, and I
Ah,
really appreciate this opportunity. I saw you. I'm at the back of that course. Then I'm just laughing in the corner, and it was in Fox Rehab. And
oh,
then
yeah,
yes, and then
of course. Oh, my
you're our
heavens. Yeah.
yes,
I was
you're
up
our
in Cherry Hill,
educator
New Jersey.
in New
Yes.
Jersey. And then I was new. I keep laughing. Oh my gosh, she's so good. She's like an actress. And then every time we watch you in different YouTube, in different
Yep.
courses, and we always use your materials. So that's why I know that every time I have dementia, we always think about you. So we are so thankful for all your techniques, and we're looking forward to learn more on the positive approach to care. So how can we connect with you, Tipa?
teepasnow.com. We have info at teepasnow.com, and we have our website, www.teepasnow.com. And we would be happy to have an interaction with just about anybody. Just give us email us or chat us online. We do chatting. And I have a great group of folks that I work with, and we have a great team. So
Thank you. Thank you so much. And I love your blogs and also the podcast with your team. There's a positive approach to care, guys, that she always aired in the morning and around 5 o'clock with her team. She always have like a 30 minutes with Matthew or the other team.
we're supposed to have 10 minutes. It never works that way.
Yeah, and also have just check out also the balance and full support group. We always air those kinds of when she was live to share, because the balance and full support group Tipa is like mixed clinicians and caregivers. So
Perfect.
I air it there, and we have many clinicians nowadays that looking forward to focus more on dementia care
Yeah.
and expertise. So we will look forward to learn more from you. So
Uh,
thank you so much. So
You
again,
are welcome.
your website is teepasnow.com.
Straightforward, just my name. It's weird enough as it is. We don't need to add anything else.
Thank you so much as well for the web for the gift that you gave to our registrants, the attendees for the Geriatric Rehab Summit. So guys, it's once again that we have Teepa Snow for our Thanks God It's Thursday. We're so grateful to learn more about the different techniques and also what is dementia. We always learn is an umbrella term. Alzheimer's is the most famous, but there are many subtypes for it. So if you have more on passion to help more people, if you have a family member, some friends who are having trouble in caring with their family members or their parents itself with dementia, connect with Tipa, and she will give us a different approach. It's not always like watch this, do this, slice, and she will show you the real scenario on what is happening there. So that way we can practice it right there and then. Okay? So thank you so much, Tipa, and thank you so much, guys. It's me again, Dr. Jenny Yusuf, physical therapist and Dr. Physical Therapy. I'm the current vice chair of the Global Health and Aging Adults Special Interest Group in American Physical Therapy Association, and your certified exercise expert in aging adults, and also your geriatric clinical specialist. So if ever you have any questions, aging adults, so now if you have any question with dementia cases and learning more, we have Teepa Snow. Thank you so much, Teepa.
You're very welcome. Thank you for doing all that you do.
You're welcome, and thank you for being our inspiration and motivation. Thank you, guys, and God bless. Bye for now.